Okay, we are very privileged to have Professor Anna Schuh here with us today. So, Professor Anna Schuh completed academic and clinical haematology training in Oxford from 2006 to 2014, and she acted as clinical director of the haematology laboratories, including the molecular diagnostics at Oxford University NHS Hospital Trust, one of the largest NHS trusts in the UK, where she's been a professor since 2014. And she's led over 50 early and late phase clinical trials in CLL as a principal or chief investigator. More importantly, in my perspective, a number of these have changed clinical practice for patients in the UK and worldwide. She served as chair of the UK CLL Forum from 2015 to 2018, and was chair of the National Cancer Research Institute Collaborative Group for CLL from 2018 to 22, and was appointed to the board of the International Workshop in CLL in 2019, where she established the Global Partnership Committee, and I know Anna is very active with the IWCLL at the moment. But she doesn't stay cocooned in Oxford and demonstrates her commitment to developing talent in low and middle income countries, where she has become a senior member of the Muhimbili, is that the correct pronunciation? Right, Muhimbili University in Dar es Salaam in Tanzania in 2019, where she delivers bedside teaching of residents and supervises MSc and PhD students. Professor Schuh has authored or co-authored over 150 peer-reviewed publications. She holds a patent in non-invasive prenatal diagnostics and has been a co-founder of 2 biotechnology startups, and of 7, a social enterprise to improve access to DNA-based diagnostics in sub-Saharan Africa. Now, I think I need to sit down and have a rest after that. But clearly a high achiever. We are privileged to have her time and her wisdom today, and we will take questions after Anna's presentation. Thank you.
Yeah, thanks a lot for the kind introduction. Okay, so I'm going to give you a whiz through CLL in 2025. What has changed, what has remained in CLL. I should also say that these 2 pictures, as John already pointed out, I'm very much still in Oxford, but I also spend about 40% of my time in East Africa, and this is the Tanzanite Bridge in Dar es Salaam. In construction, it's now finished, but it always reminds me, the gaps in the bridge there always reminds me of all the gaps that we have to bridge when it comes to healthcare provision globally. So my disclosures, there we are. So before I start, because I don't want to scare anybody, it's really important to understand that we have made such tremendous progress in the last 20 years when it comes to CLL management. And in high-income countries, the mortality of patients with CLL, from CLL, has decreased very significantly. This is the data from CAUK Cancer Registry. And you see that, since we started giving rituximab to the chemotherapy backbone, which is a long time ago now, back in 2010, the mortality has started dropping. And that was the first time we actually changed the natural history of CLL. And then the RESONATE, which is ibrutinib in relapsed refractory patients, that recruitment in this study started in 2013 in the UK. And you see that the mortality has gone down very significantly. To the extent now that some registries really demonstrate that the overall survival and the life expectations of patients with CLL is almost the normal age-matched controls. So that's very kind of reassuring when it comes to your kind of the prognosis of living or dying from CLL. Of course, there are still a lot of issues left to resolve, because it's not just all about overall survival. But this is very important data. So first I was given the remit to start off with a few facts and discuss for people who might be newly diagnosed in the audience, either physically here or on Zoom, to give a run through CLL, what is CLL, diagnosis of CLL, etc. But then I will also talk a little bit more about treatment, the principles behind the different types of treatment, and then talk a little bit about research and the work I'm doing outside of the UK. So the first thing to say is that I will use CLL and not CLL SLL, but SLL, small lymphocytic lymphoma, is exactly the same as CLL. So when I'm talking about CLL all the time, I apologize to the people in the audience who might suffer from SLL. It's the same thing. The difference is that SLL presents usually with nodular enlargement and lymph node swellings, whereas CLL presents in blood tests because we can see in the blood test the leukemia cells. So it's a chronic disease and a chronic cancer of the blood system, of the immune system. It's the most common leukemia in adults in the Western world. It results in CLL cells accumulating in the peripheral blood and in the bone marrow and in lymphoid tissues, and is more common and older. It's 2/3 male, 1/3 female ratio. We basically use sometimes acquire changes in the genes of the CLL cells to understand better whether the treatment responses of patients. And importantly, for the rest of my talk, CLL remains very largely an incurable disease for most people. And we can discuss this maybe at the end. So where does this all start? Well, the bone marrow is basically the factory of all the blood cells. The bone marrow produces the red cells that carry the oxygen from the lungs to the tissue, the white cells that are mainly fighting infections, and there are different types of white cells, the good white cells, the neutrophils, and then there's the bad white cells, which are the cells that expand in CLL. And then the little particles of cells that clot the blood, and they are called platelets. So all of this is produced in the bone marrow. Within the white cells, as I said, there's different types. You want to have lots of neutrophils because they fight bacterial infections in particular. The T lymphocytes are also important. They fight viral infections, and they're quite often not functioning properly in patients with CLL. So although B cells, the CLL itself comes from the B cells, the B lymphocytes, it's actually the T lymphocytes and the dysfunction of the T lymphocytes that is also very responsible for the infections that some people might get. In particular, the viral infections, in particular, the lack of resistance we saw during the pandemic from COVID infections. So we think that's to a large extent because of T cell dysfunction. Sometimes people call it T cell exhaustion. So like yourself, when you have CLL, you feel exhausted and fatigued. Well, the T cells in your body feel that as well. It's a disease of the immune system, so it's not like in solid tumors where when you have metastatic disease and it's in different parts of the body, that's a really bad thing. In CLL, it's normal that the disease is everywhere because the lymph glands are everywhere, the lymph nodes are everywhere. You see in green, that's the lymphoid system. The spleen is also a lymphoid organ, and sometimes the spleen is enlarged. When you bend over, you might feel some pain on the left side under your ribs, where that's because your spleen might be enlarged. It's very normal that is enlarged in CLL. Other signs, as we have already mentioned, swollen glands, repeated infections, which I think is something that still is very much overlooked. But if you ask specifically the question when people are newly diagnosed with CLL, you ask the question specifically, do you get recurrent infections? Have you needed antibiotics in the last year more than once or twice? A lot of patients will say yes. And we as clinicians have been historically very bad at picking up these recurrent infections because we always think that's okay to be on antibiotics once a year or twice a year, but it's not actually. Yeah, so pain, discomfort under the left side of your ribs is due to splenic swelling. Fatigue, I think you probably all have experienced chronic fatigue. Feeling breathless can have many reasons, but in CLL it can be because the red cells are also going down. The production of the red cells might go down because the CLL sits in the bone marrow. And the same with bleeding tendencies, nose bleeding, bleeding when you're brushing your teeth, easy bruising. All of this is because the CLL cells might be sitting in the bone marrow, and they might, they might stop the production of those components in the bone marrow. And then night sweats and weight loss. And by weight loss, it's important to say it's unintentional weight loss of more than 10% of body weight over 6 months. So that definition of weight loss is really quite important, because there's lots of reasons why people might lose weight. So how do we diagnose CLL? In this part of the world, we're very privileged because we have access to all these different types of tests. The very important test is looking down the microscope, so it's in particular for the patients with CLL in the blood, so the CLL patients. With the SLL patients, it's also looking down the microscope, but it's basically taking the biopsy from the lymph node and then putting that down the microscope. And staining it, and then you see these sort of appearances here. We call them smudge cells. They are kind of these are the CLL cells, and the smudge cells are the cells that are destroyed in the process of making the smear, and that's very classical for morphologists, in a very classical picture of CLL. These ones here, the origin thing, these are red cells, and this one is a neutrophil. So when we look down the microscope and we see these smear cells and we see lots of these lymphocytes, then we can be kind of not 100% certain, but we can be very confident that it's CLL, because it's the most common form of these types of lymphoproliferative diseases. However, there are other types that are much rarer. There's small lymphocytic lymphomas with villous lymphocytes. There's follicular lymphoma, can sometimes present in this way, mantle cell lymphoma. So there's other lymphomas. We have like 200 different types of lymphomas, and some of them can present in various ways, and you'll never have heard the name of them, but together they are not that rare. But that's why we're doing flow cytometry, because we want to make sure that it's really CLL and not one of those other rarer types, because they have a different prognosis and they also have different treatment. We use different treatment. So then when it comes to actually treating, and I agree not a diagnosis, but when it comes to actual treatment, we then do other tests these days, and I will talk about this in my treatment section, to ensure that you're basically getting the best treatment available on the basis of these molecular tests. And I'm just going to talk about the TP53 testing and the immunoglobulin analysis. I won't go through this, you'll be pleased to hear, but just to say that within cancer and cancer pathology, each cancer, and there's many of them, has a WHO blue book for diagnosis. So we have, in hematology, we have a blue book that was recently revised, and I was very privileged to be one of the editors, so I actually went through the process of writing these books. We had endless discussions about how to diagnose, what are the essential criteria for diagnosis, what are desirable criteria, which ones are the ones that we need to be able to implement across the entire world, and which ones are the ones that are okay for the US because they can afford it, but everybody else should actually say they're just desirable. So these are essentially what we came up with. We do want to have the TP53 and the 17p deletion analysis before treatment, every time before treatment. We definitely want to have the immunoglobulin analysis every time before, not every time, but once before treatment, when you start treatment. That can also be done at diagnosis because it never changes, but it's less meaningful at diagnosis. Although people who are so-called hypermutated in the immunoglobulin locus, they might not need treatment for 10 to 20 years, whereas people who are unmutated in the immunoglobulin locus, usually they need treatment within 3 to 5 years. So it gives a little bit of an indication of how closely you have to follow up patients. But the main utility of these tests is to direct treatment at the point when patients need treatment, and not before. So why did I get CLL? That's a question that very often comes up. Well, CLL is caused by aging of the immune system, basically. And that's why we see it more in older people. And also that's why we see it, probably why we see it more commonly in men and not women. We know that there are very significant biological differences between the female and the male immune system. And so it's not surprising that the incidence of cancer, therefore, of immune cancer is also different between men and females. There is a familial component, and so familial CLL has been described, but it's quite rare. And even if you do have a family history of CLL or of autoimmune disease, rheumatoid arthritis, for example, Sjögren's syndrome, all these families with those types of diseases, they are more prone to having CLL, but the risk is very small. And so that's why we don't say we should do family screening, of everybody's families when they're diagnosed with CLL. Will I need treatment? So the treatment decisions are very clearly defined there's some guidelines, the IWCLL guidelines, I bring them up in a moment. But it's very important to recognize that as many as 1/3 of patients, people with CLL, will never need any treatment. And another third do not need treatment at diagnosis. Obviously, you can imagine that changes from country to country. In Africa, where I practice, all patients who are diagnosed will need treatment because they self-identify themselves by they're anemic, they're bleeding, they have advanced stage disease. Whereas here, the vast majority of patients in the UK are now diagnosed on routine blood films because they have some other problems. They have back pain, or they have something, they're going to surgery, and so of course it's diagnosed much earlier, and therefore a lot of people will not need any treatment immediately. So in terms of managing symptoms of CLL, even patients who don't need treatment against the CLL, it's really important that we treat infections, and that we recognize that there's a proportion of people, with early stage CLL, or even the precursor, the monoclonal B-cell lymphocytosis, that those people, they might be more prone to infections, and they need antibiotics more preemptively than the general population. I would also say, I'm very old-fashioned, rather than having 5 days of antibiotics, they actually need 14 days of antibiotics, and they need, to be treated properly. That's something that very often in primary care is not so much recognized. The fact that patients with CLL have secondary immunodeficiency. If you're saying, I have secondary immunodeficiency to your GP, he will definitely give you 14 days of antibiotics. But if you're saying, I've got CLL, they will say, you fight it out. So it's a kind of, it's that recognition that you are more prone to infections, and that it's a cancer not just of the blood cells, but also of the immune cells. Vaccinations, of course, are really important. The annual flu vaccination, pneumonia vaccines, using a certain schedule, and then COVID vaccine as indicated by the NHS. And then with respect to shingle vaccinations, you need to avoid live vaccines. But there is a non-live vaccine marketed as Shingrix vaccine from GSK, and that is safe, and that is actually really good in preventing shingle infection, the outbreak of shingles. There's other live vaccines, typhoid, oral typhoid in particular, and yellow fever, just in case you want to travel somewhere exotic. There are patients who don't need treatment for their CLL, but they still need additional support for their immune system. So if the prophylactic antibiotics don't work, if you get recurrent infections, you are showing that you don't mount an immune response so well against some antigens, in particular pneumococcal, so pneumonia antigens, you might need treatment with immunoglobulins. And those are antibodies that are infused or injected subcutaneously, and they will help with fighting infections. It's not that common to have this treatment in early stages of CLL, but as you progress and had to have maybe 2 or 3 different types of treatment, then the immune system might require that additional support, because the antibody production is just not happening in the same way as it should. In terms of other issues, so anybody with newly diagnosed CLL should look after their skin, because we know that there is a much higher risk of skin cancer. There's in fact a higher risk of any type of cancer. And so often when you look after CLL patients, you'll also find that they have got other cancers. And we don't really understand why that is, although there are familial forms that's very rare, but we don't really understand this. But skin cancer is one of those, again, that is quite common. So you should protect your skin against sun with high factor sunscreen. Managing fatigue, I think this came already up several times this morning. It's very important. Now you have a good reason not to see the people you don't want to see. You can basically say, I've got CLL, I'm immune suppressed, you have a snotty nose, I can't come. And you can do that 10 minutes before the appointment, right? So use those tricks to get out of places you don't want to be in the first place, but then also, go to the things that you enjoy. So getting your priorities right is really important. Exercise, there's a whole thing about exercise. I think it's got more prominent since the pandemic. Exercise is good for everything. I mean, let's face it. Yeah, it's just a pain in the ass, but it's really good to exercise and not to overdo it. Logically, I've just done my shoulder in doing push-ups when I probably shouldn't be doing push-ups at my age. So it happens all the time that we're overdoing things. Doing it with other people is much more fun. Doing it with professionals who can guide you, and you could say, well, this is too much, this is not enough. It's really good if you can afford, subscription to the gym. But you can just get a resistant band and start doing exercises online, and there's good YouTube programs. Healthy diet, of course, that's also good. I put some stuff there that you might fancy. Avoiding too much animal fat. We all know that that's not good for us. I think psychologically it's more important to keep on track with that, with your mental health. Again, the pandemic has taught us a lot about this, but initiatives from CLL support and leukemia care really have hammered this home to us as clinicians as well, is that people do worry when they're sitting at home, they've been diagnosed, and the GP says, oh, it's a nice leukemia to have, don't worry about it, it doesn't need any treatment. When you don't have access to specialist care, you don't really think the GP has got enough competence to reassure you. So how can you live with CLL without, kind of selling your house, divorcing, going on a world trip, and and then thinking, oh God, what's my life become, right? So you need to manage your mental health, and I think it's important to emphasize that you have got rights that are laid out in the NHS Constitution, and they give you, the right to accessing specialist care, including specialist nurses, clinical nurse specialists. And all the other things, nationally approved treatment, all the other things that are there, and also very importantly, a second or third opinion. And I know that's also something that's sometimes quite tricky for patients to ask for, but you have the right to ask for somebody else to kind of give a second opinion on you in the NHS. And yes, you might have to travel a bit, or you might have to wait a bit, but it is your right. So psychological support, I already mentioned this, can be quite difficult to talk to other family members, and especially to your children about the fact that you have got a cancerous disease. There are implications with respect to professional life. I think it is really good. I'm a great believer in being transparent and being open and bringing it up. And if you can't do it alone, then ask the nurse, ask your doctor, ask somebody else to do it for you and with you, so that you're all in the room together, and that we can discuss, the anxieties and the questions and all of this, together in a nice environment. I think it's very important, because if you can't talk with your partner about your worries, or with your children about your worries, it will isolate you, and it will make you feel really lonely. And I don't think that's ultimately the right way to approach any type of cancer, and certainly not CLL, because you have to live with that for a long time. You can't read this, but that's just to say that there's not just a specialist doctor, there's a whole, and your hematologist, there's a whole range of other people that when you need treatment at some point, you can access, from dietitians, palliative care, which doesn't mean that you're dying, it just means that they might help with pain control, or with symptomatic control of some sort. You'll meet lots of different healthcare professionals, and they should all have a fair understanding of CLL. So what's happening after the diagnosis? Once we kind of know that you have been diagnosed with CLL, we've got the flow report back, that's usually when you actually see a specialist for the first time. Most of the time, as I said, in the UK, what will happen actually, we will say, we'll give you lots of information, you shouldn't smoke, you should put sunscreen on, and lead a happy life, because actually just have active monitoring. And we've discussed the mental and psychological issues surrounding this already. Now, sometimes when patients then progress to other more advanced stages, so in addition to having a lymphocyte count that is raised, they might have increasing lymph node swelling, they might get a spleen that is a little bit painful, they might get night sweats, they might become, in any shape or form symptomatic. That can be quite grey. So this middle stage, B, can be quite grey. And there's patients I say, oh yeah, you're heading for treatment, and then 2 years later they still haven't started treatment yet, because it's so grey. If they're happy to continue and they're not too bothered by the lymph nodes that are increasing, that's fine. But there will be, at some point, it's likely that there will come a time when they need treatment. Stage C disease, we definitely always treat, because that means that the bone marrow is slowing down, and so the hemoglobin goes down, the red cells go down, the platelets go down. When they go down, we want to treat, and we want to treat preemptively. We don't want to wait until you are, completely fatigued and you need a blood transfusion, or until you're bleeding and you need platelets, right? So it's much better to start treating BNA stage C when we see things are going down, on the blood tests. And that's really why we're following up people on a regular basis, so that we can start treating before actual symptoms occur. So why watch and wait? We spend a lot of time at the moment reviewing all of this, the IWCLL criteria, but there's lots of studies, including studies using ibrutinib in early stage patients. And none of those studies have shown that patients, when you treat earlier, live longer. They also haven't shown that they have a better quality of life or less symptoms. In actual fact, they get side effects from the treatment, of course, whilst they're on the treatment, but they don't benefit from earlier treatment. Now, we still think that there are flaws within those studies, so I'm not saying this is the final word. Watch the space. However, for the time being, we really think that we should stick to the guidelines and say we only treat when people have got BNA stage B or C disease, or they have symptoms. And these are the alert symptoms. So Like I said, it's progressively falling blood counts, which we will see on the blood film, on the blood tests. New lumps, persistent fatigue, weight loss, a fever of unknown cause, recurrence of symptoms that were there before, so this is for relapsed patients, drenching night sweats, sign and symptoms of hemolysis, which basically means that the body starts destroying the red cells, which is a sign that the immune system is going mad, so that's also a treatment indication. Okay, what is the treatment? This is unpublished. Thanks to Renata Walewska and others in the UK, they spend a lot of time, including myself, a lot of time kind of thinking about the new treatment algorithm. So this is going to be published very soon. It's been approved now by the British Society of Haematology as the treatment algorithm for patients with CLL in frontline. So I'm only going to touch on frontline, first-line treatment in the interest of time. What is really important when you're looking at this is that, number one, meeting IWCLL treatment criteria. So that basically means not people who are on watch and worry, but people who have symptoms, who have progressive bone marrow failure, or who have got big lymph nodes and they're increasing in size. That's number one. Number two, it's really important that we look for the TP53 abnormalities, so the deletion and mutation, and the immunoglobulin status. And that's basically because some of the treatments, it's better to give fixed duration therapy, whereas for others, it's better to give continuous therapy. So if you have a TP53 abnormality, it's better to have continuous therapy. That doesn't mean that you have to have continuous therapy, but it's, the data so far suggests that, it's more, that you'll be doing slightly better with the continuous therapy. The fixed duration therapy, it's definitely a good thing to have fixed duration therapy if you have immunoglobulin hypermutated disease. Because with fixed duration, it might be that you only need treatment once in your lifetime. Most patients, about 70–80% of patients after 1 year of venetoclax or obinutuzumab treatment will remain in remission for a long time. And they probably die of something else. And it's a fixed duration regimen, so it's not continuous, so it's relatively few side effects. So you can see how we are starting to identify the right treatment for the right patient at the right time according to the molecular marker, to those genetic markers that we are asking, only those two, right? So if you, now having said all of this, this is not written in stone, because we have to have a holistic picture, and there's a lot of patient choice in there as well, and there's comorbidities in there as well. So if you continuous therapy, this would be with a BTK inhibitor, ibrutinib, acalabrutinib, zanubrutinib, for example. But if you're somebody who has a very strong history of heart problems, right, then I would say definitely, and you have a TP53 mutation, I would definitely say, well, acalabrutinib, not ibrutinib. And I might even say, well, go for fixed duration. Yes, you will relapse more quickly, but then we can go for the other treatment after that, right? So it's not written in stone. It's a discussion with a patient. If your daughter gets married in 2 years, and you definitely don't want to be on ibrutinib, in 2 years' time, then maybe fixed duration is the right treatment. We need to discuss it. We need to weigh the options, and it's kind of gray, and everything has to be taken into consideration. Yeah, I'm not going to say much more about this, but that sort of gives you an idea of the principles of how we are looking at this. So then where are we going from here? So I'm going to give you a little bit of where we are with research, at least in Oxford, in 2025. I spend a lot of time, me and my team, we spend a lot of time developing a study for earlier stage CLL and monoclonal B-cell lymphocytosis. And the reason why we started doing this back in 2019 was really because of the Watch and Worry campaign. And it was motivated by the fact that we wanted to identify better ways of telling patients at diagnosis whether they would do badly, or not badly, but whether they would need treatment soon versus they would never need treatment. So because I was very involved previously with the whole genome sequencing program of Genomics England, I decided, well, we can do whole genome sequencing on all these people with what I call precursor CLL, right? It's either MBL or stage A CLL. Most of those people will never need treatment. But what actually happens to them? And they've been, although people have been talking about this for a lot, actually, when you look into the literature, there's been very little prospectively collected data on those people. Yes, during the pandemic, we know from hospital records that people with precursor CLL, they come in, they have bad COVID, but it's not really kind of collected as like a clinical trial collection, and the data is, some of the data is uncertain, and there's a lot of missing data as well. So we basically try to see, can we collect those people when they are diagnosed prospectively into this Oxplode cohort study. And we do a lot of blood tests at the beginning, and then after 2 years we do another blood test, and also when patients progress to needing treatment, they will have another blood test. So that study has now been going on for 5 years. It's going to stop being follow-up for the time being in September. And we have already, quite interesting data, and I just want to share some of this with you. So this, as I said, this was a study that was really very much sort of instigated by CLL Support and Leukemia Care across 16 centres in the UK. Interestingly, we tried to capture the geography, but then also smaller hospitals, because a lot of the time in the bigger centres, people are busy giving CAR T cells and doing all the fancy stuff. But in the smaller hospitals, that's where people with precursor CLL will still be seen by specialists. So we also, in Oxford specifically, completely reconfigured the NHS referral and treatment pathway through something called Oxcom, whereby we're actually offering those people a telephone support service, because we can't see them all in the clinic, but at least people who are diagnosed with precursor CLL, they have a way into the specialist healthcare system. And then they were approached through this system, so for recruitment into Oxplode. So Neve Appleby's is one of my former students, and she's now a consultant. She has done a lot of clinical analysis. There's more to be done. You don't need to understand this complicated flow diagram, but essentially what this means is that we have now prospective evidence that people with earlier phases of CLL also have clinical events. So they come into hospital, not just with COVID infections, but with other infections primarily. They might get venous thromboembolism, so they have other health problems more frequently than the normal population, but less frequently than people with established CLL. Carolyn Haddon, who is a research nurse, did some quality of life. So we collected lots of quality of life data on those people. Every time they came, they had to fill out the questionnaire, various different questionnaires. Again, just to highlight that we have now evidence that people that we knew already before, that people with established CLL have a lower rate of emotional well-being and more anxiety, and we have confirmed this now, that even in the very early stages of CLL and even the precursor, MBL, people suffer from fatigue and they suffer from emotional distress. When it comes to the whole genome sequencing data, and again, this is just for me that I remember, so don't look at it. What we have is data basically that now very clearly identifies, and we hope we'll be able to hopefully validate this in an independent cohort from Germany later this year. But we have very clear data that shows that if we are combining the immunoglobulin results together with the whole genome sequencing results, we can identify many more people who will definitely not need treatment. But equally, we can also identify more precisely, more confidently, the people who will head for treatment eventually. And this is between 2 and 3 years prior to them actually needing treatment. So it's not 10 years ahead, but it's like 2-3 years ahead, which for some people, might be, for a lot of people will be a relief, because most people actually now, with the help of the whole genome sequencing, most people will be classified as low risk. And fewer people overall will be classified as high risk. But there are high risk people where we now really know they are definitely high risk. And so those people, we might then propose in future to enter into clinical studies for earlier treatment. Because ultimately this whole idea of earlier treatment nails down to, number one, identifying those who will never need treatment from those who will need treatment, and then number two, those who will need treatment, can we cure them by treating them more early, right? So those are basically the big things that I think, we are getting closer now, and I'm being very cautious here, but I think we're getting much closer at trying to unpick where this initial, what we call risk stratification, where this will go. We also have, and I don't think I have a slide on this, no, but we also have data on the T cells of those patients, and we can see a signature in the T cells that indicates whether or not their immune system is still good or bad, whether it's good or bad. So again, the people who have an overdrive in their T cells, they are the ones who are much more likely at progressing. It's almost like, the T cells are already thinking about, oh, we need to treat this, we need to keep this under control, we need to keep the B cells under control, but actually they're probably not going to manage. And so that's an interesting point in time where you could think about immunotherapy as a very early intervention, which kind of led us to this idea of OxCure. So we are now thinking very carefully about a vaccine study. So in those very few people who we think they will definitely progress in the next 3 years, we want to eventually, ask people to enter into a vaccine study. Now that's still, far away. We haven't got the funding for it, but we have started to identify the right targets that we would use for a vaccine, and we are also very much collaborating with the Oxford Vaccine Group, so the people who invented the COVID vaccine, to basically make something like the COVID vaccine but into a therapeutic vaccine. It will be for a very small cohort of people who are at very high risk of progression. Okay, so moving slightly away, but actually not so much, because the reality behind all of this is that the healthcare that we deliver, and I'm not talking about CLL, I'm talking about cancer across the board, by treating patients with cancer in the later stages, it's not affordable across the world. It's also not affordable for the NHS. So prevention is obviously the best thing, but early intervention is the next thing after that, right? So much better to never ever get cancer or early stage cancer. But once you have it, then you have to diagnose it really fast so that it's in early stages and that you can intervene early. Because in solid tumors, for example, 90%, and that's an important number, 90% of all cancers that are cured with surgery. Right? So in CLL, that does not apply. But what would happen in blood cancers is basically saying if we diagnose blood cancers early and we intervene with some form of immunotherapy, reactivating the people's immune system, then that might also lead to cure and permanent disease eradication. So 90% of all cancers that are cured with surgery. So because they are early stage. And that's really important to bear in mind. So across the board, across the world, we also need to tackle that problem. And currently, over 90% of patients with cancer are diagnosed in late stages in low middle income countries. So anyway, so this is the map of how often people are using, if I understood this correctly, how often people are using networks that that are necessary for social media networks, to use your social media. So in red is a lot, green is intermediate, blue is very little, and black is nothing. And it gives you an idea of inequality, gives you an idea of diversity and of access, just to information, basically. And of course, goes without saying that there's very little in Africa. So with the IWCLL, we try to address this issue of access, and it's access to medicines in this case, because there is really, across many parts of Europe, even Eastern Europe, very unequal access to medicines. across the world. So the reason why IWCLL becomes an educational course is to ensure that people, hematologists and oncologists who are treating these CLL patients and looking after patients with CLL across the world, that they even know about those different types of treatments, and that they know where they would sit in their treatment pathway, and also that they know about the side effects and how to give them. So the reason why this is really, and I should say that it's an online course, and it's open to everybody, but you have to be from an LMI, from a low middle income country, practicing in a low middle income country, and it's run now for the last couple of years with live tutorials, but also like online lectures that the students can access. So some of the students are coming from the countries where the Max Foundation have now opened up an open access program of zanubrutinib. This is the data from September, so they started last year, and there's now probably about over 200 patients already on the program, primarily in 3 different countries. They want to scale this up to 28 different countries. Patients are being prescribed zanubrutinib, and then the clinicians are being trained on the IWCLL course. Most of the patients are treatment naive. About a third or so have relapsed refractory disease. The median age at diagnosis is 67. And the approval really is quite fast. It's on a patient-per-patient basis. So the Max Foundation, they have an app, and the local clinicians, they order through the app on the phone, and every 3 months they have to reorder supply for the specific patients. So Armenia, Nepal, and Ethiopia were the first. As I said, this is data from September. Ethiopia has now overtaken already because it's a huge country, and discussions are ongoing between between Beijing and the Max Foundation to kind of get into Ghana and Kyrgyzstan or some other countries, I've forgotten now, in the near future. So more specifically, the work that I've been involved with is because of a program grant I was able to get from the UK government back in 2019 for a different disease, also a hematological disease, but in children, very aggressive tumor called Burkitt lymphoma that only exists in children around the equator, and is actually the most common cancer of childhood across the world in absolute numbers. But it does not exist really in our setting. So I got funding to improve the diagnosis of those children, and then subsequently the treatment. I don't have time to go into this, and it's not of interest to you because you're CLL, not Burkitt lymphoma. But we created a social enterprise. So it's a clinic and a lab for people with blood diseases more generally. So we also see people with sickle cell anemia, and then we have CLL patients. So I see CLL patients there, multiple myeloma patients. We have flow cytometry now up and running. We have a molecular service. We very soon start TP53 testing. So we're basically bringing all these technologies and training local clinicians in the process. So that's an example. So we have now some guidelines. There weren't any guidelines. So with help of some IWCLL funding, we organized training in flow cytometry. We got the antibodies, the consumables that you need for the machine to run. We developed the guidelines, the treatment guidelines for East Africa. We did a lot around patient engagement because there was none, literally none. And now we have a very active group of people with blood cancers. It can't be CLL specific because there's not enough patients, but we're kind of making it a blood cancer specific charity. They're very active and happy. So this is the therapeutic. These are the kids. One of the kids with Burkitt's lymphoma is actually from Uganda because I work for this program. I've worked across Uganda and Tanzania at diagnosis, and then as the treatment, as they get treatment. The problem is that about half of the kids, once they've had a really good response, they relapse and then they die because there's no other treatment available. So one of the things currently doing, submitting grants and stuff. Again, with the Oxford Vaccine Group, we've developed a vaccine and we've got very good preclinical data, and we're now going into a early phase clinical study in Tanzania and in Uganda to see whether by vaccinating the kids when they've had the treatment and they're in complete remission, whether we can stimulate the immune system so that it stays, that it can fight the cancer and helps it coming back. And because we're using the COVID vaccine, a version of the COVID vaccine, it's very cheap because the university has pledged, not to ask for royalties for anybody getting this vaccine in low-middle-income countries. So this will be like a $1 vaccine, where some of the other cancer vaccines you might have heard of, from BioNTech and so on, they're about $1,000 a shot, and you need, 13, 16 shots. So you're talking very different numbers here, which is a good thing. If you want to make a gift, that's the barcode. And of course, this is my ever-enlarging group across several continents now, and thank you very much for listening.